This is a time of intense change in obesity. Our goal right now is to find sense-making of the trends associated with coverage, therapy, and care delivery. Through our conversations with physicians, administrators, payers, and patients, we've identified 7 themes: society, obesity as a chronic disease, care delivery, payment for treatment, policy, and economics. We place patients at the center. As the drawing illustrates, the themes are disconnected, yet at the same time intertwined. We begin by putting patients at the center. Policy should support coverage of all patients, irrespective of socioeconomic background. Patients remain uncertain about addressing weight loss. They are influenced by distrust for healthcare and lack of success with previous weight loss attempts. They bring concern for cost and the commitment to a lifetime of medication to address what they perceive as their own responsibility. Their body is a part of their personal identity, and we are all defined by our physical image within this world. Engaging patients through personalized care remains a focus. How will patients with obesity approach these new opportunities or treatments? Addressing obesity lives in our communities, indeed in our societies. Stigma associated with obesity remains on the rise through our own implicit bias. We need to approach care equitably. We cannot abandon the focus on prevention, particularly for families and in communities. The role of social media serves as an accelerant to providing person-focused care. How will the stigma associated by persons with obesity be addressed in our society? Care delivery should approach obesity management as it does other chronic diseases. No single strategy will exist for all patients. Rather, a multimodal approach is needed. Obesity must be clinician managed with support from therapists, counselors, nutritionists, and physical therapists. All treatment should be made available to all patients, including access to obesity medication and metabolic surgery. A 13-minute office visit, the standard for chronic disease in the U.S., falls short of providing patients with the care they need and deserve for obesity management. We must continue to look at where and how care can be delivered, including the role of telehealth and group health visits. Patients, employers, and payers are seeking successful management models. Failure to provide them within primary care will lead to alternate care models being developed through specialty organizations, commercial vendors, and through telehealth. What is the optimal system and workforce needed to provide patient-centered, personalized care? Today, every conversation on obesity management includes a payment conversation. Who will pay for treatment? How much will they pay? For how long? And for what services? To better understand these forces, we explored 6 payers: the federal government, state governments, employer-based programs, assistance programs, individual policies, including those through the exchange, and payment of out-of-pocket by individuals. The federal government has an interesting role here, both as a payer, a healthcare provider, and as an employer. State governments manage Medicaid programs as well as state employee plans. Coverage today, both within and between these sources, is at best inconsistent. How will coverage align? Who will offer what coverage, to whom, and for how long? Today, 23% of the U.S. workforce are employed by companies with greater than 500 employees. These large companies are more likely to offer coverage to minimize absenteeism associated with health sequelae. And employers know that coverage for obesity care influences both their initial recruitment and their retention of employees in a tight labor market. Employers are now asking how obesity care is paid for. Can health care dollars currently spent on wellness programs be deployed? Will there be savings within the systems? Is that enough? Can we implement direct contracting? Employers are also seeking partner healthcare organizations that can support comprehensive coverage. Employers have not coalesced on a single strategy. Some are expanding obesity care, while others are implementing time limits or weight loss requirements. Employers are looking for new strategies by embedding resources in their companies, promoting partnerships with providers, and offering virtual care through telehealth companies. There's extensive variability between what is covered and what is not. Currently, approximately 20% of employers offer some obesity coverage, with the expectation that that number may grow as high as 40% in 2025. The challenge for many companies is to manage current costs and recognize future benefits. The key question remains, what will employers provide to cover comprehensive obesity care? All eyes are on the passage of the Treat and Reduce Obesity Act, TROA, currently in front of Congress. Advocates hope this legislation, to include weight loss management in Medicare, will be the forcing function for coverage across payers. TROA is currently being scored by the Congressional Budget Office, examining both the Part B and D benefits separately. Those over 65 are lobbying for coverage, while clinicians study approaches to weight loss in an older population. Our key questions remain: how will the federal and state policies align, if they do at all? What policies will be approved by the federal government, and when? What impact will government policies have across all payers? Understanding the overall economic impact of the changing landscape is imperative. These drugs are expensive. The overall health benefit is challenging to measure. Obesity rates are rising globally, and new treatment strategies are necessitating that governments, health systems, and employers worldwide consider policies for obesity management. The economic effect extends beyond traditional healthcare markets to healthcare startups, commercial entities, snack companies, clothing designers, and product placement advertising, just to name a few. Bloomberg has labeled GLP-1 as a megatrend. Competition and reliable product availability will settle some markets, yet key questions remain. What impact will these changing approaches to obesity management have to the global economy? What are the financial risks, as well as what are the long-term benefits? We summarize our key questions here. How will a person with obesity approach these new treatment strategies? How will the stigma associated by persons with obesity be addressed through our healthcare system and our society? How will obesity management be integrated with care for other chronic diseases? What is the optimal delivery system and workforce needed to care for patients with obesity? How will coverage align? And how does this impact patients? What employer coverage will be offered in the future? How will federal and state policies align? And what policies will be developed for coverage? What impact will these changing approaches to obesity management have on the global economy? What are the financial risks as well as the long-term benefits? These questions, as well as many more, will continue to shape the future of obesity care within the United States and around the globe. We add these themes to our existing evaluation of patient and clinician needs in primary care. As we look for solutions, no single intervention will change the environment, yet together we must advance. We encourage pilot programs that link employers to comprehensive primary care, including affordable evidence-based therapies and longitudinal chronic disease management with behavioral health, nutrition, and physical therapy. Clinicians should be appropriately compensated for delivering evidence-based care, and all patients should have access to affordable care. Our focus should remain on the image of success. Obesity is recognized as a chronic disease. Treatment for weight loss is available and affordable for all. The stigma and shame felt by persons with obesity is addressed. Each patient receives a personalized approach. Policies are aligned, providing patients with ongoing care, and the needed workforce and care systems are available. As these are woven into practice through policy and patient-centered care delivery, clinicians and their patients will find a common ground.